tonight's presentation is titled Surviving and Thriving with Knee Arthritis, What the Patient with Knee Arthritis Needs to Know. And our presenter is Dr. Bryan Pack. He's an orthopedic surgeon who sees patients at our Schoolcraft location in Livonia, as well as the Brighton location. So Dr. Pack, would you like to kick it off?
Sure.
Okay.
Well, thank you, Allison. Thanks for that introduction. Good evening, everybody. Thanks for attending this evening. I want to highlight again what I just said a few minutes ago for those just joining. This is really your presentation. So, I can tell you what we do and what's based on evidence-based medicine, but the reality is that it's your knees and it's your body. And we want to make sure that we are informing you in a way that allows you to make good decisions for yourself in your individual situation. And I think that that's something that we really value at IHA. So a little bit about myself. So I moved from Grand Rapids here about 2 years ago to really help start the orthopedic program here in Livonia at the Schoolcraft campus. I'm the site medical director and am the chief of orthopedic surgery for Trinity Health St. Mary's, and I'm the chair of the Orthopedic Clinical Excellence Council for Trinity Health as a whole. Been doing orthopedics, been in practice for almost 12 years now. I did my fellowship at Rush in hip and knee replacement. You may hear that described as adult hip and knee reconstruction. If you see that someone with that title, that's usually someone who's done a fellowship in addition to their orthopedic residency, specializing in joints. So my particular specialty is minimally invasive hip and knee replacement, as well as complex hip and knee replacement, and finally revision hip and knee replacement. And for good reason that I have a passion for that. But more so, what we take care of a lot more of is not just surgery, but managing the pathology that causes the surgery. So we do a lot of conservative management of arthritis. We try to educate our primary care colleagues on appropriate management of arthritis, and we try to educate our community, you, on what arthritis is and what we can do to help mitigate the symptoms and improve quality of life. And that's really what tonight's presentation is about. So we're going to talk about what arthritis is, and we're going to spend a little time in this. The nice thing about this is that we have a format where I would love to get into more pathology and clinic visits about what causes arthritis and how it develops, because I think it's fascinating. But we don't always have the time to do that in a clinic setting. So this is kind of our opportunity to discuss that tonight. And then how you know if you have it, and how you can live and treat knee arthritis, live with and treat knee arthritis. So without further ado, what is arthritis, and specifically what is knee arthritis? And I think what's important to know is, first of all, some normal anatomy. So I'm gonna share some basic science with everyone and some anatomy. So a normal joint is where two or more bones meet. The ends are covered with something called hyaline cartilage in most cases, and often with other fibrocartilage structures, such as the meniscus, which is always a hot topic, the acetabular labrum, which is in the hip, and that's held together, that joint is held together by ligaments and capsule, as well as tendons that cross the joint, which attach muscle to bone and move the joint, okay? If you know anything about hydraulics, it's basically the hydraulic that attaches, that moves that bearing or that joint. Just as a brief introduction to the knee, this is the femur, which comes down from the hip. It's the largest bone in the body. This is the tibia here that comes up from the ankle. It's also a very large bone. The fibula doesn't provide a ton of support for the knee, but it has some importance. We won't talk a whole lot about that tonight, but it is where the lateral collateral ligament attaches. And then there's a medial collateral ligament attachment, which links the two bones in more of a stable fashion. And everybody has heard about ACL, anterior cruciate ligament, which again links the tibia to the femur, and the posterior cruciate ligament, which links the tibia to the femur. And then that's all covered by the patella, the kneecap, okay? And then finally, the blue here, I can tell you it's not blue. It's actually this brilliant, beautiful white when it's really healthy, which I hope to never see, because that's not what I operate on. But this beautiful white substance is the cartilage, the slippery stuff that coats the end of the bone that makes the joint in the first place. And then finally, you have these C-shaped structures that sit inside that joint that act as a cushion between the tibia and the femur, called the menisci. You have one on the inside called the medial meniscus and one on the outside called lateral meniscus. So what is cartilage? It is the connective tissue found in and around joints. It's flexible, it's really shock absorbing, and there are several types. Unfortunately, it's relatively slow to grow, has a poor blood supply in general, which means it has limited regeneration potential and frequently heals with scar if it heals at all. And kind of the thought was that whatever you're born with is what you have for the rest of your life. And there's some truth to that, although there is some repair capability of the cartilage over time. The problem is that when you start causing damage to that cartilage faster than what it can repair itself, then you develop destruction of the cartilage, which we refer to as arthritis, and we'll talk about that. Fibrocartilage, again, is rubber-like structural cartilage. It's a shock absorber. It offers secondary support and some stabilization of the joints, such as the knee meniscus or hip or shoulder labrum. And that, again, is these structures right here, the menisci. Okay. The next type of cartilage is also very important. That is hyaline cartilage, and that coats the ends of bones and major joints. It is extremely slippery. In fact, it has the lowest coefficient of friction known. There has not been a lubricant, even in the space age, that matches the coefficient of friction of cartilage, which is pretty fascinating and amazing. It has a high water content in a healthy joint, which helps efficiently absorb shock. And that's related to something called glycans in there that actually absorb the water, and you lose those over time in terms of that structure, and you lose that shock absorption. Typically, there's about 2 to 3 millimeters of cartilage on the end of the femur and on the tibia, as well as on the backside of the kneecap. And again, the white stuff here is the cartilage, and that's the slippery stuff. And if you see, by the way, on these presentations, I've put in some QR codes. You can actually use your phone to access that, and that gives the website where these were taken from. This is actually taken from OrthoInfo, which is a patient-centered site from the American Academy of Orthopaedic Surgeons. So what is arthritis? Arthritis is essentially destruction of that cartilage. There are many causes of arthritis. There are many forms of arthritis. The most common is osteoarthritis, which is wear and tear arthritis, or post-traumatic arthritis, meaning that if you've had a fracture or you've had a bad fall, that can damage irreversibly that cartilage and lead to wear and tear and cause problems. Inflammatory diseases can cause this, including crystals such as gout or pseudo-gout, where you get crystals built up in the joint that cause inflammation. You can have autoimmune arthritis, although we're seeing this less commonly because of a lot of the medications that are out there to help treat this. That includes rheumatoid arthritis, psoriatic arthritis, lupus, and a whole slew of other autoimmune diseases where your immune system actually in some way attacks the joint. There's structural or malalignment that can increase the wear and tear. Examples of this would be Blount's disease or other deformities that can affect that. Infection can actually cause arthritis, particularly if you have any bacteria, and that is a surgical emergency, by the way. You don't want bacteria inside your knee joint. That's bad. And all of these can be contributed to by genetics and the environment in which you work and live. So essentially, you have all of these issues that then cause cartilage destruction in some form, and that can be minimal or it can be terrible, such as in trauma. That increases inflammation, in which you get swelling and stiffness. You get joint pain, which is either localized or diffuse. You get joint dysfunction because you get altered gait, right? We don't want to walk on a knee that hurts, or we change the way we walk, sometimes unknowingly, to affect that. And then you get muscle atrophy as a result and loss of range of motion, which, guess what, puts more stress on the joint. You start getting bone spurs, and the bone underneath starts hardening. We call that sclerosis. And that leads to more cartilage destruction, which then, again, goes around in this cycle. So it's this vicious cycle of arthritis. And eventually you go from beautiful articular cartilage that looks like this, only white again, and a normal joint space, to really having that cartilage destroyed, having exposed bone, bone spurs that occur, narrowing of that joint space. Basically, you're going from a paved road, this is definitely not a Michigan road, a paved road to a gravel road. And we see that progression on an X-ray here. So just to orient you to the X-ray, this again is a femur, the thigh bone. You can see the shadow of the kneecap right here on the front, and then you can see the tibia here. And that space again, represents the cartilage here. Okay. And so this is a relatively normal knee with a little bit of arthritis here, a little bit of narrowing. Then it goes to more moderate arthritis where we see more narrowing, to a little bit more advanced arthritis where that narrowing is more progressive in the inner compartment here. And then we see these bone spurs forming. And then finally, this is an advanced stage of arthritis where not only is it bone on bone, but it's actually starting to erode some of the bone with bone spurs all around. So you can see the difference from a joint that is relatively healthy to a joint that is really not healthy at all. The unfortunate news is that arthritis is progressive. It's typically slow. It's rarely rapid destruction of the joint. So to date, there's no proven treatment to reduce the disease or stop the progression. That's really disappointing. However, the symptoms can be managed and the function optimized. So we get patients that come into the office all the time and say, well, there's nothing we can do. I say, actually, there's a ton of things that we can do to manage your symptoms and make you feel better on that knee. So then the next question is, how do you know you have knee arthritis? Well, you may have some common symptoms such as morning stiffness. You may notice some activity-related and weight-bearing pain. And usually the pain is worse at the end of the day, especially after a long day. You start getting some swelling and maybe some tightness in the joint. It just doesn't seem to be working the way that you want it to or the way that it has in the past. In more advanced stages, you might notice some more grinding and crunching, or what we call crepitation as you move the knee. You may notice some loss of range of motion and some muscle atrophy, as well as deformity in real late stages of the disease. You saw in that x-ray how that knee starts to bow out or bow in, because that arthritis can occur in any place in the joint. And typically you start getting some limitation of walking in your daily activities. It tends to be insidious. It's rare that you can point to an event and say, well, that's what happened. But it can be sudden. It can be a fall, it can be a trauma, it can be something that causes damage to that joint and again progresses from there. Again, it's slowly progressive, but it can be rapid. You may often experience a sudden increase in activity that brings it on, or I'm sorry, you may have a sudden increase in activity that brings it on, such as yard work and weekend warriors. I guarantee you that this time of year, we're going to get busy because people have gone out to rake leaves and be working on uneven ground. And all of a sudden, they're going to notice that their knees are hurting. And we see it again in the spring when everybody does their spring yard cleanup, but not necessarily. It's typically localized, but it can be diffuse. And believe it or not, you can have a knee that looks pretty bad on an x-ray and not really know you have arthritis for years and years until you set it off. So how is it diagnosed? It's really based on an evaluation, not an MRI. I get the question all the time in the office. So what do the x-rays show, doc? What about the imaging? Do I need an MRI? Did you look at my MRI? And really the answer is based off of a history, a physical exam, imaging, which we'll talk about, and very occasionally some labs, which may be to look at for rheumatoid arthritis, gout, infection, or other causes. So what can you expect when you go to a doctor's office? A complete history and possibly even a survey. Believe it or not, we collect information on validated scales on how your knee is performing, and that helps guide treatment. You will get a physical exam, or should get a physical exam, looking at the way you walk, looking at your knee range of motion, looking at your knee stability, and that includes stressing some ligaments. You'll get a little pushing and a little prodding, checking for tenderness around the joint line, the bones, the ligaments, or the tendons to try and make sure that we're making the right decision, because you can have arthritis, but you can have other things going on with that knee that need more attention than the arthritis itself, because a lot of times it's not even the arthritis causing the pain, and that changes the treatment. You can have special exam tests to exclude other joints as a source. So don't be surprised if the doctor starts rotating your hip or looking at your back or checking an ankle, because all of those can actually relay pain or put the knee in pain. Imaging, the gold standard, believe it or not, is a good old-fashioned standing x-ray, like we saw in those pictures, and I'll show those to you again. It's cheap, it's low radiation, it's quick, it's accessible, meaning that most of us have it right in the office. It usually tells us what we need to know immediately. And the reason we have you stand for this is that it compresses the space that was previously occupied by any cartilage. And that means that if you have space there, there's at least some cartilage there that's preserving that joint. Very rarely do you need an MRI, and we'll talk a little bit about that as well. You seldom need any kind of advanced imaging at all. And that's a little bit of a misnomer. We get a lot of questions on that. Again, we have x-rays to compare here, and this really tells us the degree of arthritis. In fact, we have something called the Kellgren-Lawrence grading system that validates some of the treatments that we use as well, and tells us based on evidence what works at each stage. So a knee that looks like this really looks like this inside. And a knee that looks like that usually looks like that inside. So why not an MRI? Well, it's just not necessary. It doesn't change the management. It certainly doesn't change the prognosis. It costs a lot of money. It costs a lot of time. And if you have arthritis, it's usually not very comfortable for many people to obtain lying still for a little while to get a good picture. It may find incidental benign pathology that we're not quite sure about based off of that MRI, that then requires not so benign additional workups to confirm, such as additional tests and even invasive procedures. So we really don't recommend these as the screening process or even in the treatment process for arthritis. But why would we get some advanced imaging? Well, sometimes we see pain out of proportion to an exam or an x-ray finding. Say you have mild arthritis and your pain is just horrible. Well, maybe we want to look for an occult fracture, in which case an MRI would be an appropriate management, such as a high suspicion for a fracture, but negative x-rays. Concern for a blood clot, another question we get all the time. That's really rare without an inciting event, and MRI is not the right answer for that. That's usually ultrasound. Certain mechanical symptoms, especially without improvement after non-operative management, then that may require an MRI to look for what we call loose bodies or joint mice wobbling around in that knee, some mechanical problem that could be fixed with a minor surgery versus a major surgery, although I would say that that is very rare. And then any suspected ligament or tendon injury or tear. You were in an accident, the examination shows a loose knee, and we have to work that up further to see if something that needs to be repaired or treated with a brace, and the MRI can help us determine that. Again, the physical exam really demonstrates that. The physical exam is what dictates whether or not further imaging is necessary. And then any odd finding on an x-ray, we'll find, maybe a hole in the bone or something. You go, well, gosh, maybe we should work that up and make sure it's not something more serious. Oh, but doctor, I have a meniscus tear. Yep. Oftentimes we see people who've had an MRI that shows a meniscus tear, and they may come in a year or two later. And by that time, yes, the weight-bearing x-ray demonstrates arthritis. And they frequently accompany arthritis because, again, we're talking about damage to that joint and damage to the cartilage. And what happens is that as you get a roughened surface, obviously it can tear that meniscus and cause problems. But if you just treat the meniscus and ignore the other issues, then you're going to continue to have pain, and you're not going to be happy with me sticking a scope in there to try and make that better. So it's really treated by treating the arthritis, and we'll touch on that a little bit more later. But doctor, what about this Baker cyst or this cyst behind my knee? A lot of patients will come in with pain radiating down the back of their calf that's sharp or burning or searing, and they get an ultrasound because we want to rule out a blood clot, and it shows this cyst. Well, what is a cyst? Well, real simply, a cyst is a collection of fluid. And in this case, it's a collection of excessive fluid from arthritis that as the arthritis progresses, your knee tries to lubricate itself to differing degrees, and it's different for every patient, every joint, but it builds up a bunch of fluid pressure that then gets pushed out and stuck typically right behind that knee. Occasionally, you can get something called a ganglion cyst, which is kind of the same idea, just in a different location on the knee. And that cyst content is usually stable. It doesn't usually get bigger or smaller, it just kind of stays the same way for years. And that cyst is filled with basically jelly, not to be too gross, but it's usually on the side of the knee, usually the side where the arthritis is the worst. Can be on the good side too. These are totally benign, but it doesn't always feel that way. And again, a ruptured cyst is full of that inflammatory fluid, and that just drifts right down the calf muscles, and it can cause a searing or burning pain. And how do we treat that? Again, treating the arthritis. So how in the world do we treat arthritis? How do we live with arthritis? Well, you recall this cycle that we talked about, the vicious cycle of arthritis. And really what we want to do is we want to break the cycle. So we want to prevent any of these issues up here as much as possible. We might use anti-inflammatories to address the inflammation. We might use anti-inflammatories and Tylenol or other painkillers to address the joint pain. We might use, again, different medications, but weight loss, conditioning, things to decrease the to improve the joint function. Again, things to decrease the joint stress, and things we can do to decrease the joint destruction. There are lots of evidence-based guidelines on management of osteoarthritis. And again, if you click down here on this guy right there, okay, that will go out in the presentation as well. But if you look at that, that'll bring you to this document, which is the management of osteoarthritis of the knee, non-arthroplasty. So this is non-operative management of arthritis based on evidence-based clinical practice guidelines. And these are great guidelines that we update every so often. In fact, this was updated this last year based on the data that was available. And typically they review thousands and thousands and thousands of studies to make sure we're giving you the most accurate information possible. I'm not going to go specifically into the guidelines, but the bulk of this presentation is based on these guidelines. Here's another resource. Now, this is in 2014, so there have been some updates. This is from the Michigan Arthroplasty Registry, Collaborative Quality Initiative here in the state of Michigan. And if you go to this site again, it'll bring you to this, which also includes Consumers Reports endorsement and the American Academy of Orthopaedic Surgeons. So again, there's no cure, but as we treat our general well-being, we can improve our symptoms significantly. And that includes mind, body, spirit, right? I mean, some basics in terms of health management. That was for Dr. Breaky. I know that he will appreciate that. And it's very true. Healthy diet, regular exercise, good sleep habits, active treatment of other disease processes, and specifically stressors, because inflammation in the rest of the body can cause inflammation in your joints. We really do recommend treating those and addressing those as needed. The goal that I tell every patient that comes in the office with arthritis is that our goal is to decrease stress and to decrease inflammation. We can really break it down into those two topics. Decreasing stress on the joint includes activity modification, weight loss and optimization, exercise and optimization in general. Decreasing inflammation involves medications, occasionally injections, diet and lifestyle change. So what about activity modification? Really, it's about avoiding impact activities, right? So if you're a runner, unfortunately, you may find that running is going to cause more pain in that arthritic knee. Other times, switching what side of the road that you run on, switching the type of ground you run on, making sure you're wearing good shoes, and those types of things can decrease the impact on the knee and keep you running longer. Now, keep in mind that jarring motions can increase the amount of damage that accumulates on that joint, unfortunately, right? I don't think we know of any professional football player who doesn't at some point have arthritis in the knee, okay? Smooth arc of motion activities. Non-jarring activities such as swimming, bicycling, and walking are perfectly fine for arthritis and oftentimes can alleviate pain in the right circumstances. Weight loss is important, or weight optimization, not necessarily weight loss, because everybody's goal weight is going to be different, okay? We have all these BMI guidelines and such, and they're kind of accurate, but they're approximate. And so each person's ideal weight is going to be different. The knee, unfortunately, is a 4 to 6 time multiplier of body weight under normal circumstances, such as getting up from a chair, going downstairs, going upstairs, and can be up to a 10-time multiplier. Like if you were to jump off, say, the back of a pickup truck and land on that knee, you're going to put up to 10 times of your body weight across that knee, which is considerable, right? So 10 pounds of weight loss can equal roughly 60 pounds off that knee. So it does help. One thing I wanted to add one thing. It's a common misnomer that, when we talk about weight loss, diet and exercise, the exercise component in a study performed about 3 years ago showed that more people, about 70% of people's weight loss was actually from diet modification, not actually from the exercise. Now, the exercise kind of begets those healthy lifestyles and such, but the diet is just as important as the exercise, if not a little bit more important in some cases. Studies have also shown that patients who are morbidly obese, you may that is a specific definition. So someone who has a BMI, basically their weight relative to their body surface area or height is is 40 or higher. In those patients, if they have a surgery, they've actually been known not to lose weight, but to actually gain weight, which can be deleterious to the actual outcome of the surgery long term too. And once you've had the surgery, there's kind of no turning back. So we really emphasize optimization prior to any kind of surgical intervention, but more importantly, just the management of arthritis. What about managing the stress on the joint from a physical therapy perspective? People come in all the time and they say, you know what, I'm active in my job. I'm up and down ladders. I go to the gym. I'm in CrossFit. And I say yes. And we take care of people whose quads look huge. But when you compare an arthritic knee to a non-arthritic knee, and you look at their quad strength, there is typically a difference. Okay. And that lack of optimization from the arthritis can cause more problems. And so we do emphasize some conditioning, simple conditioning exercises to improve muscle strength and balance. And guess what? That has a lot of literature to back it and a lot of data and is well supported by our Academy guidelines. It can improve muscle strength and your balance. It can improve joint stability. It can improve your range of motion and associated stiffness. And it can improve the function of surrounding joints, because as you start to develop less range of motion, start having a contracture of the knee, can't get it all the way flat, then that starts affecting your hip, it starts affecting your ankle. And guess what? That unfortunately starts to affect the same knee that's bothering you. So our goal is to offload that affected joint and make the suspension system strong. What about bracing? Well, bracing can occasionally be helpful, but not for all. It's not always tolerated, even if it does help. Not everybody wants to wear a brace, especially in the summer. And there are really two types in general. And that's a little bit of oversimplification, but there are two types. There's a hinged brace, which is for stability. And then there's a hinged offloader brace, which can actually put an opposite force on the joint to take the pressure off the portion of the joint that it has the most arthritis. The problem with that is that it is very rarely tolerated for long because it's kind of annoying to have 3 pressure points around that joint that is otherwise sore, and they can help, but again, can create some other problems too. These are available by prescription or over the counter. I guarantee you that the over the counter is cheaper. So I oftentimes encourage people to try the over the counter if they feel like they can tolerate it and they feel like it's helping, then we can move up to a prescription brace. Occasionally you need more stability than what an over the counter brace can offer. And so we will provide a prescription to help out with that. What about management of an acute flare-up? Okay, this is oftentimes described as an exacerbation of knee pain. Remember RICE, rest, ice, compression, elevation. And I learned this playing high school football. Not that I was good at it. I had a lot of opportunity to use this. So rest, ice, compression, elevation. Rest is to minimize the additional stress on the joint in an acute flare-up. Ice is just to cool things down, causes vasoconstriction and decreases the inflammation. Compression, such as a sleeve or an ACE wrap or a compression stocking, can provide support, and then elevation again to decrease the swelling. What about management of inflammation? We really split this into different things: oral medications, topical medications, injections, supplements, lifestyle and diet, which I'm not going to get into that as much because it just isn't my specialty. I think that's a really evolving field and very interesting, but it's certainly not where my training is right now. So oral medications include anti-inflammatories, painkillers, opioids, supplements. We'll talk about each of these. Non-steroidal anti-inflammatory medications or drugs known as NSAIDs. These get a lot of press, both for good and for bad. There is a ton of support for their use in management of arthritis because it does significantly decrease pain and symptoms. We often talk to patients right before a joint replacement who have to be taken off of these because it can thin the blood a week before the surgery. And I ask, so how are you feeling today before your surgery? And they say, you know what? That naproxen was actually working. I didn't think it was, but it was making a big difference. And I'm kind of upset that you made me stop it. Yes, these medications do work well. They're typically cheap. They're typically widely available. There is no difference in potency in terms of an ibuprofen versus an naproxen versus the more prescription versions like meloxicam or Celebrex or diclofenac or nubumetone. I've included all of these names in here just so you can kind of familiarize yourself and be familiar with what you see over the counter. It is a common misnomer that a prescription is better than over the counter. Now, the dosage may be different, but you can still take the same amount of ibuprofen through more pills, obviously, as you would get in a single pill from a physician. And oftentimes I recommend the over-the-counters because you can tailor that a little bit better to your need instead of having to take a massive dose like a prescription would offer. So what are the pros? Well, they've got a long history. They're well studied. They significantly reduce inflammation and pain in most cases. They're readily available and they're inexpensive for the most part. What are the cons? Well, here's where they get the bad press, right? This is, well, may increase your risk of cardiovascular event, or in at-risk patients, stroke, heart attack, may cause you to die. And unfortunately, yes, they have a black box warning. I don't want to minimize that. Okay, that is important. It can increase the risk of cardiovascular event in at-risk patients, but usually we're talking at long-term usage. So a little bit here and there is probably okay for most people, but we do recommend that you discuss with your primary care doctor, or if you have a cardiologist or other cardiovascular doctor, probably a good idea to discuss beforehand. GI upset or ulcer, renal disease, they can increase blood pressure, they can increase your bleeding risk, and you can't take if you're on blood thinners. They sound great, don't they? Honestly, they're a good medication in the right circumstances. And that's the case with most of these things that we're talking about. Recommendations are, again, check with your PCP. Do not take if you're taking other anti-inflammatories. And the reason I listed them out here is so you know what other anti-inflammatories you may be taking. Be careful because oftentimes they include these in other medications. So you have to watch very specifically in there what you're taking. We don't recommend that you take if you've had a bariatric surgery, unless you've okayed that with your bariatric specialist. Certainly if you're on anticoagulants, any history of or any active kidney problems, again, would certainly discuss with your primary care doctor and watch your blood pressure when you're starting these. So recommendations, take them as needed. If the pain is worse, try for 1 to 2 weeks at a time, then try to wean as tolerated. If you need to take it a little bit longer, okay. If you're 4 to 6 weeks in, and it's not really helping, maybe time to see a physician. What about oral medications? Well, acetaminophen, right? One of the oldest medications and fortunately well-studied non-narcotic painkillers there is. Obviously, we hear all the time, Tylenol doesn't work for me. Where we see its effect is it can augment or help some of the effect of other anti-inflammatories. And you can, in fact, take it if you're taking an anti-inflammatory. It can augment the effect. By itself, sometimes it doesn't work for folks, but for a lot of people, it does help. And it's especially safer in our elderly population. It's cheap, it's widely available. Again, it's generally very safe, but you have to take it at the right prescription or at the right dosage. I shouldn't say prescription, but the right dosage for it to be helpful. It can be taken with other medications. Some cons, it's not effective for everyone. The formulations are unbelievably confusing. I mean, when you go through a pharmacy aisle and there's Tylenol Arthritis, Tylenol PM, Tylenol fill in the blank, right? We also recommend you avoid it if you have any liver problems, because this is a medication that's metabolized by the liver. If you tend to drink a lot of alcohol, you have to be really careful with this because this can adversely affect the liver. A few years ago, it kind of got into the media spotlight and it was kind of broadcast as poison. We know that that's not really true, except that if you're taking too much of it and if you have other liver problems. So recommendations, I'm going to come out right and say it. Avoid the Tylenol Arthritis or Tylenol PM or any of the ones that are kind of the specialties, because they're typically just more expensive versions of the same thing with either a higher dosage or another generic added to it, such as Benadryl. By the way, that's Tylenol PM, okay? Recommend that get the generic 500 milligram extra strength Tylenol, and you can take up to 2 of those up to 3 times a daily. Is safe for most patients. And again, caution if you're consuming alcohol or have any history of liver disease. And it shouldn't, unless you're taking higher doses, affect like Coumadin dosing, but you do have to watch your INR with anything that's affecting your liver. What about opioid narcotic pain medications? I can't say enough how highly discouraged these are for management of most arthritis. Okay. There, and this, by the way, this QR code for this one is for Michigan Open. We actually have a registry in the state of Michigan that really helps us give evidence-based facts on management of opioids, both for surgery and for non-surgical problems. So if you have any interest in this, this is a great resource. They're run at the University of Michigan. Chad Brummert and his team over there are just doing an excellent job, and we really appreciate their work. They're very addictive over time. As you take them longer, you decrease the efficacy, and it decreases your pain tolerance while increasing the need for higher dosages. It's also associated with poor clinical outcomes both before and after surgery. So our recommendations now are that you decrease your opioid usage before surgery by at least 50% for 6 weeks beforehand to allow your body to adjust a little bit, to accumulate or to acclimate, so that we have the ability to control your pain post-operatively. That's not really on the topic of today's discussion, but it just gives you an idea of how important it is to try and avoid these if we possibly can. For those that are using it, you really need someone who knows what they're doing in terms of prescribing, and someone who can help make sure that you're taking the appropriate dosage and also using multimodal pain approaches to avoid this as much as possible. And there are some circumstances where it just can't be avoided. Patients who can't take Tylenol or NSAIDs and that kind of thing. So we totally get that. We only use in patients in more extreme circumstances. Expect that an orthopedic doctor is not going to prescribe these except for an acute injury such as that requiring surgery. What about oral supplements? We could spend a whole seminar talking about just oral supplements. It's a big topic, and there's all sorts of data all over the place. There is lots of marketing, and I can tell you very clearly there's a lot more marketing than there is research, unfortunately. So the most common that you will see are glucosamine chondroitin, chondroitin sulfate. And if you walk into Costco, no plug for them, but if you walk into it, you will see towers of turmeric. Okay. So does it work? We'll talk a little bit about it. What about tart cherry juice? Now, I'm originally from the Traverse City area, so I have to give a plug for tart cherry juice. There may be some conflict in there, but if you go to this link, that's a link to the Cherry Festival. The CBD is one that gets a lot of topic, and I will tell you, there is not a lot of data on it. There's not a lot of good data, I should say. I will tell you, I have patients all the time who come in and say, it works. Is there a downside? And that's really the question. And the answer is we really don't know because it hasn't been studied very well. So my recommendation is buyer beware. These are expensive. Usually if it's not working after a couple of weeks, it's not going to work for you. In general, there's not good data. The data that we do have is small sample sizes, small groups of people studied with significant bias, meaning the company that is producing these is putting a lot of funding into showing that it is really effective. Beware of those studies. The 1 or 2 studies that I have seen that have been really good studies, such as a randomized controlled trial for glucosamine chondroitin, showed that it was effective in 2/3 of patients. They improved their symptoms, which was unfortunately the exact same as a placebo, a sugar pill. So mind over matter, maybe in a lot of these. My point is that if it works and you're not allergic to it and it's not causing a problem, probably not terrible. But do remember that just because something isn't a medication doesn't mean it doesn't have side effects. The US does not require FDA certification for nutraceuticals, meaning they don't have a high level of research that goes into it. And the vast majority, like I said, are probably benign, but I can't endorse that statement with research. I'm sure there will be there will be questions on that. What about topical anti-inflammatories? Well, Voltaren gel is something that just, it's been on the market for probably about 10 years. That may be an underestimate. It used to be by prescription only, and those prescriptions used to be really expensive. And a lot of insurance companies didn't cover it. It recently, in the last couple of years, went over the counter. Same formulation, same concentration to my knowledge, and it became a lot cheaper, although it's still relatively expensive. I'll give you that, okay? Best place to pick this up is at usually a buyer's warehouse kind of thing, like a Costco or a Sam's Club, occasionally on sale at other places. This is an anti-inflammatory that is absorbed through the skin into the local area where you apply it. You can use it twice daily, and it's shown to be effective for localized pain control and is endorsed by research. The pros are that it's safer than an oral. It can be taken in limited quantities in patients with other typical contraindications, in some cases, even on blood thinners, right? It is great for localized pain control. It really is for a lot of things, a lot of tendonitis, a lot of localized arthritis in one compartment. The cons are that it can still absorb into the system, though not as frequent. You don't get as frequent GI side effects, but you can get them. And it's expensive. It's not great for diffuse pain, meaning pain all over, and it shouldn't be taken with other anti-inflammatories. What about other topicals? Here again, I can't really recommend for or against, but they're available. For some people, different gels, lotions, ointments, patches can help. Some are local anesthetics like lidocaine. Salonpas is actually a lidocaine patch. Some of them are menthol type where they cause a warming or cooling or simultaneously warming and cooling sensation. And then pain relievers like capsaicin. And for a lot of people, these work. CBD, again, question mark. It's starting to be studied more and more. And I have a lot of patients that swear by it. So I don't necessarily discourage it. I just don't have enough data to support it. Now into injections. So the most common injection performed is a corticosteroid. There's hyaluronic acid. We'll talk about that. Platelet-rich plasma and stem cells are going to be the hot topics. So in general, none of these reverses or repairs arthritis, even stem cells. None of them reverse or repair arthritis. Most effects are to decrease inflammation. They're limited in terms of the number you can put in a joint per year. There's no surgery in the same joint for 3 months afterwards, just as an FYI. So if you're thinking, oh my gosh, I want surgery in 2 months, but I got to get through these 2 months and get an anti-inflammatory, get an injection, that can delay surgery. Some of these are very expensive. So what about cortisone? Again, it's a potent anti-inflammatory. I tell people, think of it as a fire extinguisher. It puts out the flames. We've used it for eons, okay? It's well proven in terms of decreasing inflammation, okay? Although several studies have recently come out that say not necessarily all the time. There could be some deleterious effects, and certainly we're cognizant of those. And typically where I use this is someone who has diffuse inflammation. If you have mechanical pain, it's probably not going to help with that. If you have pain that when you load that joint at one specific area and it's during that specific activity, it's probably not going to help with that. But if you have diffuse pain and swelling, it'll probably provide some relief for that. Typically, patients can expect 6 to 12 weeks duration of the effect, and it can be spaced at least 3 months, should be spaced at least 3 months apart and only as needed. The cons are that can again accelerate degeneration. And in patients who already have advanced degeneration where they're starting to get some erosion of the bone, we try to avoid it, okay? It does have diminishing effect, no more than 3 per year per joint, and it can increase the blood glucose. No surgery can be performed again after until 3 months afterwards. Hyaluronic acid. HA is an important component of healthy cartilage, okay? It's derived from rooster comb that's purified, not chicken fat. I hear chicken fat all the time. It's very funny. That is not what it is. It's originally thought to nourish or lubricate the remaining cartilage. Now, the remaining cartilage. So it's not real great for advanced arthritis. It's usually given in a series of 3 to 5 injections, depending on the type of injection, 1 week apart, depending on the agent itself. There are a few single injections available. They have come under fire for more painful post-injection reactions, almost like an autoimmune response. And you can actually have something called pseudo-infection, where the knee swells up like a balloon and it looks like an infection. Sometimes you have to be worked up for that. If it works, you can get anywhere from 6 weeks to 6 months of relief. And again, pros and cons. The cons are that there have been 12 peer-reviewed, high-quality, randomized controlled trials that, again, demonstrate no difference versus placebo. You can get a pseudo-infection reaction with excessive pain. They are expensive. They do require an insurance authorization, and not all insurances cover them. In fact, a few years ago, some of the main carriers just stopped covering them altogether, and it became a little bit of a battle. That's improved because there are some people that do benefit from this. And I would say people with that moderate degree of arthritis where they're not bone on bone can have some improvement. Not all the time, and there is a downside, of course. And really, I would say the same as of cortisone. The series, if it's going to be repeated, has to be over 6 months apart. And that's kind of dictated by insurance, but some guidelines as well. What about platelet-rich plasma? Basically, the process is the blood is drawn, it's spun down in a centrifuge. The plasma is taken out, the platelets are separated from that plasma. The platelets are diluted, and that's kind of where some of the expense is, because each company has their kind of specific dilution that is supposed to have a different effect. And then it's affected into the joint. I think there may be some advantage to this. Now, we don't do it in our office because the data doesn't support it quite enough. We are following that, and we will see where that goes. But again, there's limited evidence. And again, there could be a downside, okay? But I would stay tuned to this one. What about stem cells? These are highly marketed. They are extremely expensive, okay? And by extremely, I mean, so let's just a little comparison. The cost of an implant for a total knee replacement, okay? Not advocating that, but the cost of an implant is somewhere between $3,000 to $4,500, okay? Average, okay? For stem cells, the cost is about $5,000 out of pocket. There is no insurance that pays for this. Why? Because there's no data, no good data that endorses this. They're the data that we have is highly variable in terms of the method they use to measure it. It's highly variable in terms of how they prepped it, how they got it, where they got it from. They get it out of the hip fat. Well, is that truly a pluripotent cell? And there's no standard. There's no evidence that it actually rebuilds the cartilage in a human joint, okay? Now, there is some evidence that it may help with some mouse models or rat models, but that's not us, and that doesn't necessarily translate to a human. It may decrease inflammation, and what we're seeing is some marketing to that effect that, oh, this will decrease inflammation. They are considered experimental. They're under scrutiny from the FDA. They've actually shut down a couple of clinics because of false advertising and some concern with that. And so we do not currently recommend these. Again, science is evolving. We will see change likely in our lifetime, but not something we would recommend right now. Certainly not something I would have done. So what if none of this is working? And again, we will get to your questions. I'm sorry this is such a long presentation, and I'm willing to stay late and answer those. But so the first is, what happens if all of this fails? Okay. And I've still got symptoms, and it still hurts, and I can't function in normal stuff. Okay. Arthroscopy, meaning we stick a scope inside the knee, we clean out the knee. This used to be done very commonly. And we did it because we thought we would improve mechanical symptoms, and we thought it might be helpful. Keep in mind that you go from a paved road to a dirt road. And so what are we really accomplishing inside that joint? Are we filling a couple gaps? Are we cleaning up the shoulders? I mean, what are we doing? So in general, it's not really recommended for arthritis, and that is supported with the Academy statements. In general, there may be some certain indications, such as if you're having mechanical symptoms where you have like a cartilage flap that is locking the knee up, and you just can't mobilize, or you can't trust that knee, you're going to fall downstairs. Well, in that case, it may be indicated, but the result of it is not fantastic, right? So it may get rid of that acute pain, but it usually progresses the arthritis, because what are you doing? You're clearing away more of the pavement, okay? So we have to be a little bit careful with how we select that. And I believe that most surgeons are in that case. What about knee replacement? So a hot topic, right? And again, we can do a whole seminar on this. I'm not going to get into a ton of detail, but just real basically, this is a resurfacing of the knee. A knee replacement involves restoring or improving the mechanical function of an otherwise arthritic joint. It is not cutting off the entire bone and filling it with metal, okay? It's a little more elegant than that. In fact, I saw one hospital advertisement that stopped advertising as knee replacement and started selling it as resurfacing, knee resurfacing. So they're the same thing, just for clarification, okay? You can do partial knees where you're replacing only the arthritic portion of the joint, but if there's arthritis through that joint, or if there's autoimmune disease, then that's not the right answer. And there's some specific instances for partial that can help. And a lot of these, most of these are going to end up as total knee replacement, which is well backed in the literature as well. We want to reduce inflammation of the joint by improving the mechanics and improving the pain and function. It's typically a 6 to 12 week recovery to get to that 80 to 90% of where you will end up. And ultimately, it's a 1 to 2 year continual optimization. So even if you like it at 6 to 12 weeks, you will typically continue to improve and adjust over the course of a year. Minimally invasive techniques, which is what I personally specialize in, can make for faster recoveries and easier recoveries. And this is often done outpatient now, going home the same day. And that is a service that we offer as well. It is very different from even 10 years ago in terms of how we manage these. And again, I'd be happy to answer some questions on this. Some additional resources in terms of discussion of arthritis, I recommend the Arthritis Foundation's website. This is a beautiful website that talks about all sorts of facets of arthritis. The American Association of Hip and Knee Surgeons has excellent resources, including arthritis, as does the American Academy of Orthopaedic Surgeons. And finally, if you really want to dig into the literature and want to look at some of the data that's out there, orthopedic guidelines, we have a very specific way that we look at data. And it is, I will say I've participated in these, particularly with workup of infection after joint replacement. This is a great resource if you really want to delve into the research on it. And with that long presentation, I would be happy to open it to questions.
Okay, that was amazing. And Dr. Pack, I tried to kind of start to go through the questions that are already there.
Great.
So I took a couple notes and we can get started. But if you have questions for Dr. Pack, you can type them in the Q&A feature, which is at the bottom of your Zoom screen. Look for the little speech bubbles. Go ahead and type them in there and we will do our best to answer as many of your questions as we can. So the first topic that I saw is kind of repeated several times from several different people is kind of the timing that comes with knee replacement. So how do you know when to get a knee replaced? And what does the recovery look like? And then the time between if you have to have both knees replaced.
All right, great questions. So let's start with, how do I know it's time to have a knee replaced? Well, you have to meet two major criteria. Number one, you should have advanced arthritis. So if you have moderate arthritis, studies have shown that if you have moderate arthritis and lots of pain, those patients don't have predictably excellent outcomes. Okay, so there's something about that if you replace that knee and not all the cartilage is gone, patients don't do as well. So that's part one. Part two is you have to have symptoms that match that arthritis. I see a lot of patients who come in and we focus. The reason I don't show the x-rays first is because I don't want them to fixate on that picture that you saw all the way to the right, that Kellgren-Lawrence 4, okay? Because a lot of patients will have tendonitis. They will have patellofemoral syndrome, and I want to actually talk about that a little bit later on here. But they will have symptoms that can be managed very, very, very effectively with non-operative management. And so the first thing I would say is really optimization of that knee to know that the arthritis is driving the pain, that the mechanical problem is driving the pain. And then a mechanical problem that is driving the pain demands a mechanical solution. And that's where you can benefit from knee replacement. So we're very specific about that patient selection. I always tell people knee replacement is not an exploratory or experimental surgery. It is to fix a defined problem. One question that we have often is, boy, I have lots of pain, but I'm not yet bone on bone. And oftentimes it is going back and refocusing and making sure you had the right physical therapy, making sure you had the right conditioning exercises, because if you don't do it right, you can actually cause more problems than good. The next question, knee recovery. I'm going to talk a little bit about minimally invasive because that's what I do. And everybody has probably a different spiel in terms of knee recovery. What minimally invasive does, minimally invasive knee replacement, is number one, use smaller incision, yes, smaller cosmesis. We typically do not go up into the tendon itself, the quadriceps tendon that is. I don't know that it has a huge effect, very honestly. The way I learned to do it was to split the fibers of the muscle, keeping the bulk of the muscle intact. And I do think that helps a lot of people. More importantly, we're actually putting the knee through range of motion while we're doing that. And so we're causing less stress on that quadricep and the tissues around the knee because we're using the knee's native motion to get access instead of just dislocating the knee all at once, which is more of the traditional approach. and doing that entire surgery. What that affords you is typically a faster recovery. Patients are able to do a straight leg raise earlier. We use conventional implants, meaning we use implants that have strong backing with data. The Michigan Arthroplasty Registry, of which we're a member, and I'm actually the one of the co-chairs of the device committee, where we're looking at those devices. We don't want to use anything that doesn't have good data. Okay. And so we use implants that have good data to back it without compromising your long-term outcome. The upshot is a faster recovery to get to that long-term outcome that is the equivalent if you did a traditional. So what's the recovery? The first 2 weeks are usually the hardest. Day 1 to 2 days out, you're not too bad. Day 3 to day 4, your body figures out that it had surgery and it's not too happy about it. So you get a lot of inflammation and then and pain. And at the same time, we want you moving that knee. We want you working that knee to get your motion back. So it's a lot of physical therapy. It's a lot of you doing the exercises to stretch the knee and get the swelling down. And usually by about 7 to 10 days, you start actually liking that knee, start thinking it was a good idea to have surgery. My picture usually comes off the dartboard by that point. Somewhere between 2 to 4 weeks, most people are starting to feel better than they did before the surgery, or at least having that sensation more often than not. Still messing with sleep, but at that point, you're starting to get back to driving. If it was your right knee, if it's your left knee, it's as soon as you're off of any pain medication or narcotic pain medication. By 6 weeks, most people are about 80 to 90% recovered. And that's a bell curve, right? So you have some people that it took them 3 months to get to pushing a cart on level ground. And the soonest I've had a patient go back to golfing is 3 days. I do not recommend that. But they were very happy in Florida. Again, I don't recommend that because it can compromise your entire recovery. And then the rest of the recovery after 6 weeks is rebuilding muscle. So the better you come into the surgery in terms of your strength and flexibility, the reason why we stress exercises, the better you're going to come out of that surgery and the easier it's going to be.
Excellent. So what about age limits, meaning what is the youngest age that you would suggest undergoing surgery?
70 to 80. No, I'm kidding. It really depends on the patient and the pathology. So honestly, the youngest patient I've had to do a knee replacement, I say had to because we tried everything else, with someone who had severe arthritis related to a disease condition, was 22 years old. That patient is at a high risk of having to have it redone at some point, by the way. The oldest patient who have performed a knee replacement, again, in that shared decision making, making sure that the family was on board and making sure the patient was, of course, on board, was 89. My cutoff for surgery for knees is different from hips because knees are a harder recovery than it is for hips. Hips are much easier. So, we'll do hip replacements pretty much as old as someone is, as long as they can walk. For knees, it's different. You have to be really engaged in your recovery.
Great.
Allison, I want to go back to anterior knee pain because I've seen that question pop up a couple times. Front of the knee pain or knee arthritis in the front is treated a little bit differently. Okay. And the reason is that a lot of the pain that you get on the front of the knee is related to your quadriceps strength and a balance between body weight and stress relative to the muscle strength. And if that's not addressed, even after a knee replacement, unfortunately, I just saw someone regarding this a few days ago had an isolated patellofemoral replacement where you just replace the front of the knee and no improvement because the other issues weren't addressed. So the outcome, even if you have a knee replacement, if you haven't addressed that issue with pain on the front, then you're not going to have a good outcome. And so it's really, really the right conditioning exercises. Even if you've done PT, in most cases, people just have not done the correct type of physical therapy. So be very open to that if your doctor recommends PT to strengthen the muscle in the right way.
Okay, as you kind of scroll through the questions, I see one here that it looks like this person is a chronic runner. Has had chronic knee pain, is a long-term runner. For me, I'm not a runner, so I would say that would be a chronic.
It can be kind of chronic, yeah. I get that.
So it's a chronic knee pain for 12 years and a long-term runner who's relatively young. They say, I have the most difficulty with extended standing. I can't stand for more than a minute or two without leaning on something or continually shifting weight. Can you talk a bit about why it's so difficult to stand because it feels better to walk or run?
In most cases, it's your quadriceps, believe it or not. It's not, and it can be your glutes as well. And so it's optimization of that quadriceps. And by the way, that's not doing squats necessarily, because that increases the contact pressure. Let's talk a little bit about that. So squats are where you're putting load in what we call a closed chain. So you're basically squatting down and standing back up, and you're putting a load on the front of the knee, but it's a really efficient way to build the muscle. In fact, it's the most efficient way to build the quadriceps muscles. The problem with that is that you're also putting stress on that knee, which is also painful. And so patients will do it for a little while, and then their pain increases, and then they stop doing it. And then their muscle atrophies more. And so it exacerbates the problem. So we're very specific on doing some straight leg raises to just start that process, and then getting into squats as that muscle gets stronger, because then you're decreasing the stress. But most of the time, endurance, pain going downstairs instead of just going up, getting up from a seated position. Patients say, I can't kneel. And you ask, well, can you kneel? Oh yeah, I can get down, but I can't get back up. That is typically not a function of the knee joint as much as it is a function of the muscle strength relative to the condition of the knee, if that makes sense.
Okay. Do you have a question that you see you'd like to answer? Or do you want me to keep going here?
Here's a great question. Is ibuprofen better than naproxen? The answer is maybe yes, maybe no. The reality is that each of our body chemistries is very different. So ibuprofen works great for me for a headache. Doesn't do a thing for joint pain for me. Okay. My brother is the exact opposite. Same genetics, right? Yeah, it's really specific to the patient. And unfortunately, there's some trial and error. We do not have any genetics testing yet that indicates one or the other. What about those who take warfarin to control inflammation? It's tough. It is tough. If it's okay with your doctor and your INR is well controlled, and your pain is relatively isolated to a specific spot, over-the-counter Voltaren gel can be used. Obviously, Tylenol around the clock, you got to be a little careful. You can take up to 1,000 milligrams every 8 hours of that. And then cortisone injections oftentimes help. And again, optimization.
Dr. Pack, I saw a few questions that were saying the people are having trouble with walking or exercise because of their pain. And can you recommend an alternate? Would that be something like swimming? Or
yeah, swimming is great. It's finding the exercise that works for you. And oftentimes walking can exacerbate pain, especially depending on the ground. If you're walking on a sidewalk that's uneven or walking on uneven ground, then that can be problematic. It's finding the exercise that works best for you. And sometimes that's engaging with a physical therapist to try and figure that out. We certainly have great physical therapy offerings through Trinity Health. Mercy Elite, I'm going to put a plug in for them. Trinity Elite does a really nice job of sports training and kind of helping you find what activities are best for you. We work with Probility, who also does a fantastic job. Our partners in determining that. So if you find that even those activities aren't helping, there are other things that can help you determine what will get you more active. I would also advocate for progression, right? Even when we're in tip-top shape and we're trying a new sport, we're not necessarily the best at that sport when we try it out. We're not Michael Jordan, right? So, gradually working your way into a sport is really important, or even just walking is important.
Okay, Dr. Peck, someone was asking a clarification question. So on your NSAID slide, you said it reduces the risk of CV issues, and they were wondering what you meant by that.
Oh, no. So the naproxen and Celebrex have since been studied. There was the original study, I think was 2006, that came out that said that anti-inflammatories have an increased risk of cardiovascular events, stroke, heart attack. And obviously that was very concerning. It was what earned them a black box warning from the FDA. And you pick that up and it looks terrifying, right? Since then, there was another study, I want to say it was around 2016, that showed that naproxen didn't seem to have the same CV risk as some of the others, and that the way the original study was conducted was not consistent with the way we would conduct the study nowadays. and that when compared to a control, it actually had no significantly elevated risk of cardiovascular effect. I always question any study I read. So it has been associated with a lower risk of CV event, cardiovascular event. But again, best person to talk to is your cardiologist or your PCP if you're considering that and you are at risk for cardiovascular event.
Great. And Dr. Pack, there are several people asking, can they make an appointment with you? So you are accepting new patients. And
Yeah.
what is the best way to do that? Do they need to go through their primary care phizician to start? Is that the best route?
You can
to you, or
actually,
can they
you
call
can
you
actually,
directly?
yeah, you can actually call our call center and just give
Great.
us a call, and we can guide you through that process. We have really a great group of folks who can tell you, yeah, probably need to talk to your primary care doctor first, or depending on your insurance, no, you can come in and see us anytime.
Perfect.
And
Okay.
we do have an 800 number, which is 866 ortho IHA 866 678 4644. I had to think.
That was faster than I could have done it, but we will include your contact information and contact information for the all of the ortho locations in the email that we follow up in case somebody is maybe closer to a different location.
Yep, absolutely. I see another question I'd like to address here. It
Yeah.
says, can arthritis show up on MRI? This is from Carrie. Can arthritis show up on an MRI, but not at all on an X-ray? Yes and no. So if you have early arthritis, you may see some changes in the cartilage. You may see some cartilage shearing off, that kind of thing, on the MRI, but not on the X-ray. The interesting thing is it, again, doesn't really dictate management. You manage the arthritis, which is the same way, management of the stress, management of the management of the inflammation in the joint. In some cases with an acute injury where you don't have arthritis or only minor amount of arthritis and you tear the meniscus, arthroscopy is a great option. And we certainly have providers that do that very, very well and make it look super easy. And the recoveries are good from that. But if you have a lot of arthritis or moderate arthritis and you have meniscus tear, that's a totally different thing. There's a question in here, how long will a knee replacement last? It varies by patient. The original reason why we had to revise knees at 15 years, 90% would last 15 years. The original reason that we revised, meaning you had to reoperate, change something out on that knee replacement, was more for plastic wear, meaning the plastic would just wear out, the bearing surface would wear out. That was that white thing between the metal things on the picture. The reality is, with the newer plastics we're using that we had some questions about 10 years ago as we switched over, as we've watched the data on that, the plastic is lasting longer. So that has moved now 90% at 20 years. Can you end up with a revision at 5 years? You absolutely can. Most common reasons for revision at that point are going to be infection, unfortunately. And we in the state of Michigan have taken a dramatic undertaking to reduce the risk of infection, really a partnership of orthopedic surgeons and hospitals across the state of Michigan through the Michigan Arthroplasty Registry to improve and decrease the risk of infection. And we're proud to say that that rate is among the lowest in the country. But that is still one of the highest reasons that patients get revised. And then unfortunately, mechanical complications. So the knee is put in not perfectly or doesn't match the mechanics of that patient's joint. So that's one of the reasons that we are just very, very vigilant about how we do that. You may hear something about robotic knee replacement, very hot topic. And the goal is to address the revision rates from patients failing early because it's not put in right, not aligned right. And the data for folks who already are doing a good job of aligning, the robot doesn't really help. Those who are doing lots of joint replacements a year, it hasn't been shown to help things dramatically. Now, again, science is evolving. We may see some changes. We're certainly open to those changes. But where it seems to help is people who aren't doing a whole lot of knees, who do have some issues with alignment. That isn't to say that everybody uses robot has issues with that. There's some really great providers who do it, but that's one of the causes for revision, unfortunately.
You talked a little bit about knee pain sort of being caused by quads versus the actual knee. Is that if you have knee pain, can it cause pain in your hip, or can that kind of refer other places as well?
Great question. Actually, one of the most common reasons that, well, I wouldn't say it's the most common, but it is a not uncommon reason that we see patients for knee pain is that they have really bad hip arthritis. And the way that they're walking because of their hip is actually stressing the knee, and they're not feeling pain from the hip arthritis, which highlights the fact that you can really manage arthritis and not have problems with it for years. But they're getting the pain in the knee. So if you're getting hip pain, it may be the quadriceps. That's where the quadriceps attaches, or one of the attachment points. It could be the way that you're walking. It unfortunately could be some hip arthritis or hip pathology going on there too. One of the things I love this statement, yes, forgive me if I'm mispronouncing the name, Canu, Meta. I hear motion is lotion. Yeah, motion is lotion. Yeah, the folks who are the most miserable aren't the people who are out there working hard at getting their knee, keeping their knee functioning. A lot of those folks are putting off surgery for a long time because they continue to maintain their function, continue to maintain their range of motion. Some of the most miserable patients that I see on a regular basis are the folks that just give up. It just hurts too much, and they just give up their activity. They're not stretching on it. They're not keeping it as active as possible. And the reality is that some degrees of arthritis just warrant that, right? You just can't do it. Totally get that. But the more you're doing exercises, particularly low weight bearing, low stress exercises on that knee, even yoga, they do have yoga for arthritis specifically, that the better that knee joint and other joints are going to function, and probably the longer you can stave off surgery. What about copper braces? Opinion on that. This is opinion again, because there just isn't a lot of data. I love the copper fit braces at Meyer. Why? They're cheap, they fit well, and has nothing to do with the copper. There's not good data to support that the copper helps. So, I wouldn't advise anybody to go out and spend a bunch of money on copper or something like that. In fact, just the management we talked about, unfortunately, I see a good number of patients who've gone through a lot of these expensive things for many years and just not had good improvement, and not necessarily been able to go out and play tennis again and golf, or go for that walk. And a lot of things that we do make it better without a lot of risk to the patient. So yeah, beware of stuff like that. Magnets are another one. And I always say, if magnets worked, the hospitals would be marketing them, because they have some of the most powerful magnets there are. They're called MRIs. So I haven't ever seen someone come back and say, oh, wow, that MRI made my knee better. So
That would be amazing. We talked a lot about different types of shoes. Is there something specific that people should be looking for to help alleviate knee pain in a shoe?
great question. So one of the topics that has been studied is putting in an insert, like a wedge insert in the shoe. And that has been shown not to be effective. However, I would say a shoe that has good padding, a shoe that addresses any foot deformity that you have, or tendency that you have. There's pronators and overpronators. I am not a foot and ankle surgeon. We have a great foot and ankle doctor here, and some great podiatrists here as well. They are more informed about that than I am. But one that improves your alignment for your feet and your ankle, and one that really has good cushioning, so that you're not beating your knee up. I always tell people it's a lot cheaper to invest in an expensive pair of shoes than to reinvest the money in a new knee. So some food for thought there. We talked about patellofemoral.
Yep, go ahead, Dr. Peck. Sorry to
Oh,
interrupt.
we talked about patellofemoral. I'm just scrolling through. Is pickleball contraindicated due to twisting motions? It's not contraindicated. You might, if you're doing a twisting motion, though, you might find, number one, that can really exacerbate pain symptoms, make them worse, right? You might find that you have to go to RICE again, rest, ice, compression, elevation, after such an event. That's a point where I might consider using a brace. You see braces used in football players to avoid injury. that can be helpful in arthritis. And, then you're not wearing it all the time. You're just wearing it during a specific activity. And that can be helpful. Absolutely.
What about acupuncture?
Acupuncture. So the original guideline in 2013 kind of came out against that, showing that there wasn't significant improvement. And when I was reviewing the guidelines, honestly, I'm going to be very honest, I can't remember what the newest guideline said. I will say anecdotally, purely anecdotally, I've had patients that this has helped. There is a technique called dry needling that a physical therapist performs. It's different from acupuncture, and I won't go into the specifics. But basically poking around that knee or ligaments around the knee, and I don't want to sound like I'm an expert on it, but the Academy did come out and say that there is no data to support that. Very, very limited that ever uses or ever works. What devices for knee replacement do I use? I use a couple different systems based on patient anatomy. I typically use what's called the Zimmer Persona system. This is not an advertisement for that company, although I think the major companies we work with have been very good. They make good implants. They have good lasting data on them. There are some other implant companies that are kind of on the, like, I want to say experimental, but maybe experimental end. So I use stuff that has good data to support it. The other one is a Attune that I will use in some circumstances. And a lot of it is just based on the demand of the patient and their anatomy. How do you treat bone spurs? You don't. If you take a bone spur out, it comes right back. So this is kind of cool, actually. Why do bone spurs occur? Why do we get bone spurs? There's something called Wolff's Law. Okay, and what Wolff's Law basically says is that as you increase that your bone responds to the pressure that it receives. So if you don't put pressure on bone, the bone goes away. Okay, if you do put pressure on bone, it gets more dense. Bone spurs are a result of that law, meaning that as the cartilage, the shock absorber, the padding goes away, you get more pressure on the underlying bone. And how can your body handle that? It can increase the surface area of that bone, which decreases the contact pressure. Very cool, right? Pretty amazing that our bodies figured that out, or was designed that way. Either way, those bone spurs can actually help until they don't. And then they dig into other tissues and can cause pain. So how do you treat bone spurs? You manage the arthritis again. And sometimes that means knee replacement. When we do a knee replacement, we do remove any appropriate bone spur, which is most of them, if not all of them, to clean up the knee and make it function more mechanically correct. Does a bowed knee require immediate knee replacement? Oh, that's a great question. Not necessarily. So there are lots of causing of bowing. Basically, if you have a joint that's kind of a rectangle, and you lose the cartilage on one side, then your knee is going to bow. Doesn't matter if it's in or out, it's going to bow. And so when we replace that and straighten it out, again, the knee becomes straight. The other reasons that the knee can bow is that the tibia and the femur can actually subluxate against each other, meaning that where they're lined up, they can start going away, and that can stretch out the ligaments. And in that case, knee replacement can be strongly indicated urgently rather than waiting on it. And again, a physician can make that assessment. Knee clicking. I'm pointing out at this one because this is a common question we get. Knee clicking. There are lots of things that cause a knee to click. There are lots of things that cause a completely healthy knee to click, believe it or not. You have not only the two bones moving back and forth as not quite a hinge type mechanism. There's actually, your knee is a very complex motions. There's rollback of the femur on the tibia. There's rotation of the tibia on the femur. And then in the middle, you have your kneecap going back and forth. So knee clicking can be the cartilage itself. You can have cartilage tears that click. You can have the meniscus that clicks. You can have synovium. If you get inflammation in that joint, you can actually have synovium. The lining of the joint gets inflamed and swollen and can catch between your kneecap and your knee or your femur, and that can cause clicking as well. So some of that is managed. You can actually get knee clicking to go away by getting the muscle strong, by decreasing the inflammation, believe it or not. And then sometimes, obviously, it's bone on bone, it's gravel clicking against each other, and then warrants other treatment options. Pain and stiffness in the back of the knee. I see your question, Kathleen. Yeah, immobilized with pain. That is miserable. Most of the time, not all the time, most of the time that's going to be related to something like a Baker cyst or the arthritis itself. And the best thing in a lot of those circumstances, and again, would warrant an assessment. One of the best things you can do is stretching of that knee. In a lot of these cases, if we just can't get any further with stretching, a cortisone injection can help if there's arthritis there too. But a lot of that pain and stiffness is usually related to, again, that arthritic process, and it can be a Baker cyst. How do we treat a Baker cyst? That is a common question we get too. We do not recommend draining a Baker cyst. There are actually a bunch of neurovascular structures in the back of the knee, including the artery that goes right down to your ankle and provides your foot. Your foot wants blood. If you go after that too aggressively, you can get into trouble. The biggest reason is that they just recur. If you don't treat the inflammation, then you're going to continue to have swelling in that joint from the fluid produced, and it's going to get ejected out the back of the knee and cause more pain. So again, management of arthritis can cause that to shrink. When we do a knee replacement, we don't remove the Baker cyst, again, because of the reasons I said. But oftentimes what we'll do is we'll open it up bigger so that fluid has a place to egress, to get out of, and then we suck the fluid out of it. Obviously, it can collect with other inflammatory fluid in the recovery process, but typically it will go down, if not disappear, and sometimes scar in. All right. Any other? Oh, I see Kathleen said it isn't a Baker cyst. You might need an assessment. Recommendations to strengthen pain, strengthen the leg to lessen pain. Yeah. That Academy website, that Ortho Info, has all sorts of exercises on there for the knee. Again, I would avoid anything that's a squat initially, really emphasizing leg lifts and that kind of thing, as well as even some hip exercises. Those are the exercises we frequently use with some caveats in there. And we're hoping to have a website up. I don't know, Allison, can I forward you some of the exercises we use?
Yes, that'd be amazing. And I'd be happy to include them.
Cool. I will try to remember to do that. So, have you ever had knee surgery? Great question. No, I have not, but I'm headed toward it. So my dad is going to be having knee replacement. My mom has had both knee scopes and knee replacement. So it is in my genes, and certainly I get the symptoms. So I try to practice what I preach, and my wife will tell me when I'm limping, she'll say, "Are you doing those exercises that you taught me?" Yeah, no, I should go back to doing those, and it works.
What about the neoprene wraps? Kind of those simple slide-on wraps.
They can help. They provide some compression. Unless they have a side brace to them, like a hinge, they're not really providing necessarily a whole lot of support. But they can keep some compression on that joint, which can decrease the symptoms.
Same story with the tapes, all the different tapes we see.
Absolutely.
Okay.
Yeah, I have patients who swear by them. I see them actually work post-operatively to help with post-op bruising and swelling. They work really well. Draining fluid from the knee, we don't recommend doing that unless you have a massive, what we call effusion, where your knee has just generated a bunch of fluid inside of it. We don't really recommend draining that because it just keeps coming back. Now, if you're going to have a cortisone injection and you have a ton of fluid in there, sometimes it's not a bad idea to pull the fluid out before you put the cortisone in there, to decrease the swelling and make room for the cortisone too. And you're not diluting it out that way. But in most cases, we don't recommend draining. Is revision the only solution to surgical knee to start hurting again? Not necessarily. And again, depends on a workup. If you try to make an appointment with me for a knee that has already been replaced, you'll find that we have more limited appointments times for those because they take longer to work up. There are lots of things that can cause that surgical knee to hurt. And so we use a little bit more time to work those up, just FYI.
It looks
Do I
like,
ever replace both
oh,
knees at the same time? I do not, because I like my patients. I actually love my patients. So the reason is that studies have shown, even though it's safe, even though it's effective, most patients who have both knees done at the same time have about 10 degrees less range of motion on average. And my biggest reason is that if you have a complication with one during that, again, it's rare, but if you do, it's a major issue for your recovery, and it can compromise both your outcomes. So I don't like putting both my eggs in one basket there. The closest I'll replace them is 6 weeks apart. That's not for everybody. A lot of people will opt for 3 months. Sometimes replacing one knee that was just really dysfunctional actually allows you to take the load off the other knee. Other times you replace that knee and you realize how bad and how many things you weren't doing before that now you want to do with your new knee, and so you end up having to have the other one replaced. So it goes one of those two ways.
so what if you need your hip and knee replaced? Do you have a recommendation of which one you should start with?
Oh, that's a great question. It depends on the exam. So if you have a hip contracture, meaning that your hip doesn't go all the way straight, and there's a very specific way to test that, and your surgeon needs to check that. If you have severe hip arthritis and I really should say any deformity, and the hip doesn't go straight or it rotates out, and you do the knee first, you're going to have a harder time, and you're going to be at a much higher risk of that knee failing. The hip typically should be done before the knee, especially if it's symptomatic or it has contractures. The hard discussion on that is when a patient comes in and they're not having any symptoms, they're not having any pain in that hip. All of it seems to be in the knee. In fact, you do a cortisone injection in the knee and all the pain goes away. That's a bummer, because they still have that deformity of the hip. And if you replace that knee, you will end up with contractures of that knee that can't be fixed. So usually we recommend replacing the hip if it's severe before the knee. I
Okay.
see that great comment from Gene. I do silver sneakers through Medicare and my knees have improved 100%. Yeah, that is a frequent thing. So don't be afraid about PT or working those knees out. All right.
So it looks like there's one more question I've seen a couple times. Why can't you have a cortisone shot before surgery?
Oh, great question too.
Yeah.
And really this goes for any injection. The studies were recently repeated for even HA injections. It increases the short answer is it increases the risk of infection within 3 months of the surgery. And if an implant gets infected, it's unfortunately not as simple as just throwing an antibiotic at it, or putting you on even an IV antibiotic. It involves significant surgery. You have to actually sometimes take the implants completely out, put a temporary implant in that helps kill off the bacteria, plus an IV antibiotic for 6 weeks, and then go back in and replace the knee. You can tell why we've spent so much time and so much effort to decrease infection in the state of Michigan, and we're still working on those efforts to make it the safest place to have a joint replacement in the country. So one of those guidelines is that we don't recommend doing a cortisone injection within 3 months of the operation, and that includes the HA as well. Do you check out the hip prior to doing a knee? We absolutely do. In fact, it's one of the reasons why we do a long leg alignment X-ray, and we also rotate that hip around to see if it is acting up. And Maria, I see your question. Can you explain why the leg bows out? And we talked about that a little bit earlier, but it's as the cartilage goes away on one side, then you end up with that tilting, and so the knee will bow out. So if the cartilage goes away on the inside, then it will bow out. If the cartilage goes away on the outside, it will bow in. If it goes away at the same rate in both places, it oftentimes will be still straight.
So interesting. Okay. If you see any other questions, Dr. Pack, you can keep going here, but I think you've made it through a majority of them, at least the topics, if not the specific question.
Sure. And I apologize for those who didn't get their questions answered. happy to answer those in person as needed too. And we'll be
Absolutely.
posting this. Some of it may have additional information that you missed. I'm sorry, it was very dense. But just want to thank everybody for coming tonight. Here's our building. You may have seen it on 275, beautiful new building that we're very proud of. But we're more proud of just seeing patients here. And if we can help in any way, we're happy to do so.
So this was an incredible presentation. Thank you so much. I know it's been a very long day for you. I think I speak for everyone who joined tonight saying that we are so appreciative of your time and expertise. We will include all of the contact information for Dr. Pack and the entire ortho specialty, so you can see where all the locations are and all the different physicians available. So look for that in the next few days, as well as the recording, which will also be posted on our YouTube channel. So with that, thank you so much, Dr. Pack. We appreciate
Thank you, Allison. And
yeah.
thank you, everybody. Have a great evening.
You too.
All the
Bye-bye.
best. Good night.
Good night.